let's jump in. So we have a brief conference today. We have a 38-year-old female who has a history of depression, anxiety, and PTSD, who is coming to the hospital with extreme fatigue, muscle aches, bloating, and swelling in her hands and feet for the last 3 months. On further questioning, she actually lived in Pueblo before becoming unhoused and moving up here to the Denver area. She has a child who's pretty sick and has actually been hospitalized at Children's for the last 2 months. And so she's been spending a lot of her time and energy taking care of her kids. In terms of her review of systems, she had no SI, no HI, no insomnia. She has no infectious symptoms, really otherwise negative aside from the information that's listed there. For her past medical history, aside from her psych history, which is noted in the HPI, she has a history of endometriosis, for which she's had 9 laparoscopic interventions, and then postpartum depression. For her social history, she has a 20-pack year history of smoking. She's working on quitting down to about half a cigarette, every couple of days. And then, as I mentioned before, she's recently moved from Pueblo to Denver to access better resources for her sick child. Is currently unhoused in the area. And for her medications, she's really not been taking anything for the last 3 months because she's been taking care of her kid. Had no active prescriptions on file. Questions, clarifications? She's not on any meds. Yeah, nothing consistently. Okay, so let's scoot ahead to her ER course. And so she comes into the ER. Her temperature is 36. Her heart rate is 40. Her blood pressure is 112/75. Her respiratory rate is 18, and she's sat inclined on room air. And so with somebody coming in with this, sort of vague constellation of symptoms, I want to know, if you were the ER provider, what would be your targeted physical exam and what labs would you order? And I'm especially curious in hearing why you would do what you do and why you would order what you want to order. So talk with your tables for about 1 minute and give me at least one physical exam thing that you target and one lab that you would want on presentation to the ER. I think Lynn is the only person here who knows this patient, so. Lynn, don't give away our diagnosis, okay? You can do it either way you want. I just need at least one from each table, so. All right, let's come back together. I'm gonna start here with table 3. So could you guys give me one physical exam thing that you would look for? And then one lab that you'd be interested in getting. And if you have more, that's okay. You can share more too. I just want at least one from every table.
Yeah, we thought that examining hair would be maybe helpful, like TSH,
Okay, what are you looking for in her hair? Okay.
Are you finding her? Are you like taking her hair and trying to snap it, or what are you doing?
You wouldn't find that the
Great. Okay. Middle table. What is something that you guys would want to do in terms of a targeted physical exam or lab workup for this patient, and why?
We've been like lister loss,
Okay, and then so you're worried about fluid on her lungs. What about her history or presentation drives that sort of interest for you? Okay, so she's talking about that swelling. And then a CMP, you said? Okay. Last table.
Same on a good thought.
This thing, the like slow, I don't know the name of it, but it's like specific for hypothyroidism. Like it's like slow feed, reflex, they're like slow.
Delayed relaxation.
So, okay.
You can also do this the skin thickness on like your knuckles or something. And that's just I would not have it.
So checking for reflexes, looking at skin thickness, primarily worried about thyroid issues, and then what labs would you guys want? You can pick something different
Like
than
a
what's up
CBC,
there.
CBC.
A CBC? Okay.
I'm trying to picture the middle of their table, actually, what the hair looks like hypothyroidism, because people always talk about.
Yeah,
people
yeah.
hair,
Go
so
for
this is a thyroid thinning, yeah, it's like thinning, long snap, so that's. And so when you say brittle hair, it's not like take your hair and try to snap it.
And also like, there's like those lateral third of your eyebrow.
Yeah. Okay. Anything else that anybody's worried about, wants to examine, or wants to test for? A pregnancy test. Very smart. Yeah, so Nico brings up a great point. We don't often see women of childbearing age here at the VA. So like, what if she's just pregnant and that's why she's so tired? A great thing to not miss. And then Sam mentioned AM cortisol. Describe your reasoning to me for that again.
Had 9 surgeries before, like endometriosis, she has some
Mhm.
constellation, they test AI.
Yeah, so maybe concerned about AI, has her endometriosis infiltrated her adrenal gland, who knows? All great thoughts. Okay, let me give you some more information and then feel free to jump in. So I'm gonna show you her physical exam that the resident had taken on admission. And so she was alert and oriented, she had delayed reflexes. She was bradycardic, despite the fact that she talked about having swollen hands and feet. There was no edema on exam. Lungs were clear. Belly was soft and non-tender. She had no goiter or any sort of neck pathology. And her skin was warm and dry. And then let's jump ahead to her labs. And so we got mostly everything that I think that you guys had wanted, plus some extra. So her CBC is fairly unremarkable. She's got a mild anemia. Her BNP, mild hyponatremia, mild hypokalemia, and then a creatinine of 1.1. We don't have a regular baseline in our system, so not sure if this is, an AKI or where she stands. And then for her LFTs, as a reminder, it's written total protein, albumin, bilirubin, AST, ALT, alk phos. And then you can see her inflammatory workup was negative. CRP, ESR, TROP, and BNP were largely normal. Questions on this? Okay. There was one lab that table 3 wanted, TSH. Do you guys want to guess what her TSH was? 80, 100,
Normal.
20, normal? Okay, well, behind door number 3, we have, oops, deleted all of it. Let me see if I can move this. It's been a little finicky. Nope, not doing it. So I'll just write it out for you guys. So her TSH and free T4 were checked by the ER, and her TSH came back around 327, and her free T4 was 0.2. I might be off by 1 number. The number will come back again later on in her presentation. Okay, so we have a very clearly abnormal lab finding, but let's jump ahead to her chest x-ray. I'm going to give you guys about 30 seconds to go over this with your tables. And then if I could have a medical student volunteer to take the iPad and highlight any abnormalities. If any of you want to raise your hand up front, I'll know who to come to. If nobody volunteers, it's going to be you, Lynn. And then we'll go from there. But take about a minute, talk with your teams about any significant findings here.
I've heard that before. Unless you just like.
Okay, any volunteers to walk us through their read of the chest X-ray?
Stabilization, negative pulmonary edema, and just some general pulmonary congestion. And also negative pulmonary edema. Otherwise, also trying to keep good, no consolidation.
Okay. Yeah, so no pleural effusions down here. Costeophrenic angles look good. Maybe some concern about pulmonary edema or enlarged pulmonary vasculature. Any thoughts or comments on that by, let's say, an upper level or an intern?
Repeat the question.
So we've raised the question of saying maybe some pulmonary edema or pulmonary vascular congestion. Any upper levels or interns want to take a stab at commenting on that from your read?
Doesn't look like terrible to me, but I think just actually looks like very bronchopathic for signs of why I don't see a great like cross, like maybe here you consider this cross section of a bronchi and it's kind of easy, then that could speak to volume too, but I don't really see a great clear one, but just terrible.
Yeah. Yeah, so per the radiologist read, no evidence of pulmonary edema or pulmonary vascular congestion. Any comments on the heart or anything else going on there? So good question. We often see a lot of older people with lots of comorbid disease. And so her lungs may look big or her lung fields may look big, but it's actually normal for somebody who's 38 and otherwise healthy. Okay. Yeah, so really no acute findings here on her chest X-ray. And then let's jump ahead to her EKG. And so again, I'll give you guys about a minute to look over this EKG. And then let's have somebody from table 1 talk us through their read of it. Yep, that's your table. So take about 30 seconds with your teams, then we'll talk about the EKG.
Yeah.
Okay, table 1, what's your final read of this EKG?
So I think it's sinus and about 60 and most notable for like low voltage.
Okay, sinus Brady. Oh, let me get rid of that. And low voltage. Any questions by anybody else? Other things you guys want to bring up? Okay, that's correct. Sinus Brady, low voltage, nothing else was really commented on for this case. All right, so now we have our basic data. What I want you guys to do is give me a problem representation for this patient. So I've given you her age, her sex, and then her prior medical conditions, since that always seems to trip people up. But I want you guys to fill in the blanks. So work with your teams, and I'll ask each table to come up with their own problem representation for this patient. And then once we have that, we will take a stab at how to manage this lady who's going to get admitted to the hospital. And so when you come up with your representation, whatever you say is your final diagnosis, I want you to give me your management strategy for it. So we'll talk through each of your diagnoses. Hopefully you guys come to a similar one, but if not, we'll talk through the differences in your plans too. All right, I'll give you guys about 3 minutes with your teams to talk through this, and then we will come back together.
See what else? So they have a conversation.
All right, let's come back together. Any volunteers for a table to go first and give us their problem representation?
Said 38-year-old female with anxiety, depression, presents with generalized malaise and lower extremity edema, found to have TSH greater than 380 and sinus rate cardiac concern.
Okay, so profound hypothyroidism, final diagnosis. Middle table, what did you guys say?
Very similar. 30-year-old female, anxiety, depression, presenting with fatigue, muscle aches, high H, cardiac concern.
Okay, last table, anything different? No? Okay. What is something that you guys have to think about when someone's coming in with profound hypothyroidism? Yeah, so myxedema coma. Do you guys think that this patient has myxedema coma? Seeing some no's. Do you guys know what the criteria are, what we look for a patient with myxedema coma? Also seeing some no's. Take 30 seconds, use whatever resources you got, and tell me what you think would be important to take note of if a patient, if you're concerned that a patient could have myxedema coma. And so 30 seconds, you guys can just start shouting out whatever you find, and I'll throw them up on the board.
I get up to outside of this hospital?
You have to log in with your like UCH records and or like log in if you do it through the library, and then you can log in once on the app and you'll be able to access up to date all the time.
So do it just from the library link.
Yeah.
I knew that it was.
And like once you like log in on your phone with that username and password, then you should be good to go.
There's like a, there's like a scoring system, I'm not sure what it's called, but you
Yeah.
have their temperature, their CNS effects, their GI findings, their event, their cardiovascular dysfunction. and metabolic disturbances.
Yeah. Anybody find any metabolic disturbances specifically? Yeah, so low sodium, hypoglycemia, yep, hypercapnia. Okay, so now that we've done a quick Google for these symptoms, it's important to know sort of what the bad end state is of a disease that you're admitting, because this will dictate whether or not you have to get consultants involved. So looking at these things, low temperature, CNS findings, GI findings, precipitating events is usually like an illness that someone presents with. Low sodium, low glucose, hypercapnia. Does our patient fit any of these criteria?
She's a precipitating of pregnancy as opposed to the parturition.
Precipitating event with pregnancy.
Well, parturition, I guess. She's that as opposed to her child a couple months ago, it sounds like.
The kid is like 3, so
Okay,
he's older. Sorry, I didn't give you that information. And it will say she had a negative pregnancy test, so that was checked.
Okay.
Yeah, so there's a question there, right? Like she's hyporeflexic. So could that be a CNS finding? The one that we typically think of is like people, you'll hear like myxedema coma and you expect the patient to be obtunded, but they don't have to be obtunded to fit the criteria for myxedema coma. They could just be somnolent, a little bit confused. Obviously depends on their other comorbid factors. This lady was like up in bed talking, like had no issues. The other things that, just to be mindful of, so her temperature was 38 when she came in. Her sodium, I think, was 134. Her glucose was fine. She was not hypercapnic on her BMP that we checked. And so, she sort of toes the line of seeing, does she quite meet myxedema coma criteria? Probably not, with her mental status being as good as it is, but something to think of. So that way you can figure out, do I have to call endocrinology or not when this patient's admitted? Okay. Did you guys get to discussing management options for this lady? Okay. Middle table, what would you want to do for her? Okay, you want to start levothyroxine. How much? Just toss out a number. 100 IV, 125 IV or PO. Okay, so I'm going to write down what I hear. PO, 100 IV. Let's say she weighs 70 kilograms, standard. Okay, so weight-based, 1.6 milligrams per kilogram. And do you want to do IV or PO, Evan? PO. Third table, what are you guys voting for?
I'll do
150 PO, okay. Anything else that you guys want to do for management of this patient aside from starting levothyroxine? Endo follow-up, great. Planning ahead for our discharge.
We were talking about stress dose steroids as well in her. Like, she may be on the border of this, like severe hypothyroidism versus coma. And also stress dose.
Yeah, so we should talk about glucocorticoids. So glucocorticoids, do we stress dose her? What's something that we could check to figure out if somebody might need stress dose steroids in the setting of severe hypothyroidism? You can do an AM or you can do a random. Yeah, so we can check a random cortisol. I can't spell. And anybody have any ideas for cutoffs in their head about what would be okay or not? Yeah, typically in the teens can be appropriate for a random. And so for somebody where you're concerned about possible adrenal insufficiency in the setting of hypothyroidism, as long as they're greater than 10 to 12 here at the VA, it's usually okay to just proceed with thyroid replacement. So we can check a random cortisol. We can talk about giving her some levothyroxine. Anything else that anybody wants to do for this lady?
Social work.
Social work consult for her homelessness, great. Why do you want to get an echo? Yeah, so what particular findings would make you want to get an echo? Just want to hear you say them out loud.
Because of her low voltage and her history of hypothyroidism, I want to just make sure that. Thyroid.
Yeah, oh yeah, or even, what's the other thing we worry about with hypothyroidism and low voltage? Yeah, so pericardial effusion. Great, excellent points by all. So let's talk about what actually happened to this patient when she was here. So for her hospital admission, she came in on admission, endocrinology was spoken to, and they actually recommended IV levothyroxine 100 milligrams for 2 days to start her up front. But the endo fellow wanted to make sure that she was not going to go into adrenal insufficiency or adrenal crisis. And so they had checked at cortisol that evening and it came back normal. So they were okay to proceed with IV levothyroxine without any stress dose steroids. You can see there that on admission, her TSH was 327. On day one, she came down, she came up actually to 354. Her free T4 was also going down. And that was after 2 days of IV levothyroxine. And then on her, second day that she was fully in the hospital, it actually switched her to PO levothyroxine. You can see that her TSH just was not really responding and her free T4 was kind of all over the place. And so let's pretend that we don't have our endocrinology colleagues here. What would you guys do in this situation? So you've started this patient on theoretically her treatment for this problem of new hypothyroidism, but she seems to not really be responding to the IV dosing. And so what are other things that you would want to test her for, or other management things that you'd want to do to figure out if there's a bigger issue that we have to uncover? And so take about 2 minutes in your groups and you can do anything. So like asking the patient for more history, you can get more labs, you can do more management tests. Feel free to explore with your teams, then we'll come back and you guys can talk me through what you would do in this situation. Questions? Okay, take it away.
Really interesting.
Oh, yeah.
Okay, I'm hearing some great discussion. Let's come back together. Let's start maybe with table one. I heard you guys talking about a lot of different endocrinology things. Do you guys want to share what you would do in this situation with a patient who's not getting better and sort of what came to mind for this case?
I think interfere with so just talking to see if she's taking any supplements or if she's still taking what she's here.
Yeah, great.
I forget the names, but there's like some of the some of the endocrine. I also know like if the levels are too high, like they're artificially skewed or something. I forget any details beyond that, but-
Like, we could check a thyroid level and somehow figure out what's free versus like down.
Yeah.
like TPO and too.
Okay, yeah, so maybe checking some other antibodies. So I'll put that under, let's see, I'll put a spot for physical and I'll put a spot for labs. So I want to check some antibodies.
she clinically improved at all, or is she the exact same clinically? Like,
She's about the same
Oh,
clinically. Yeah, so not too much has changed. Middle table, anything else that you guys would do?
Checking a T3.
Checking a T3 level? Okay. Any other stuff that y'all want to do?
We're talking about like uptake studies and stuff that all that.
Uptake studies, okay. Last table?
Yeah, it's like antibodies T3, type of numbers, T3.
All that very high.
Okay. All right, so I agree. We have to make sure they're not taking anything like a biotin supplement that could be affecting their TSH levels. She was not taking anything at all, so we can eliminate that. When somebody has a pituitary process that's going on, or like a concern for possible pituitary process, what are some other questions that you could ask them to figure out, like, is this just a TSH issue or is this like a bigger pituitary issue? Yeah.
Periods.
Galactorrhea, her menstrual cycle,
Headaches, vision changes.
headaches, vision changes, excellent. And then physical exam, what would you do to sort of partner with that?
So like, vision field testing.
Yeah. Visual fields. Okay. This particular patient, I'll tell you that she had noticed some galactorrhea in the last couple of months. Her menstrual cycles have been abnormal. No specific headaches or vision changes that she's noticed, and we said she's not taking biotin. Her visual fields were normal on exam. And then any other labs that you guys would want to check? Prolactin, okay. Okay. I am going to also give you a little bit more information. So admittedly, this patient was on my service and I probably did not do as good of a job asking her questions as I should have. But I'm going to show you some representative information that our endocrinology colleagues were able to get from her. And so when she wasn't responding as expected, Endo and our team said, okay, we maybe have to do a little bit more investigation to figure out, is there a bigger pituitary process going on or not? And so Endo had chatted with her and she told them that over the course of the last couple of years, she'd noticed that her teeth had started to spread apart. She felt like her jaw was getting a little bit larger. The like swollen hands and feet. She said that she couldn't wear her wedding ring anymore. She felt like her shoes weren't fitting the same way. In terms of the galactorrhea and periods, that just had been like somewhat abnormal over the last couple of months while she's been dealing with all of this, stress with her son, and then also being unhoused. She wasn't really sure what to make of that. We know that she's not pregnant. She had the negative urine pregnancy test on admission. And so what do you guys notice about these photos? So she was able to share pictures of herself with the endocrinology team that she had on her phone and her laptop. Yeah, so you can see that there's definitely a gap that's widening, like in her teeth, and her face was like previously a little bit more oval shaped. Now is sort of like a little bit more square. What are you guys concerned about when you see somebody who has these symptoms? Yeah, one more time louder. Yeah, a growth hormone secreting pituitary tumor. And so, or acromegaly, like being the clinical diagnosis for a patient like this. And so Endo said, hey, we should probably rule out a different process that's going on in addition to her thyroid stuff. And so I'll push this aside. What labs would you want to order to evaluate somebody who now has these new complaints and these new facial features that you've picked up on for your exam? So we said prolactin, IGF-1. What about her like irregular menstrual cycles? What would you check? Louder. Yeah, perfect. FSH, LH, and there's one more that goes with that. Yeah, estradiol. Okay, and then we already have her TSH, and we had checked cortisol. That was normal. Okay, so we're going to send these off, and they're going to be pending because they don't come back right away here at the VA. What are some other things that could affect how somebody absorbs their TSH? Yep, how you take it. So not taking it with other medications. She's here in the hospital, so we know she's getting it and not taking other things at the same time. And so what other organ system is important for absorption? Just even more general, the GI tract, right? So what are some things that we could check for the GI tract to figure out if it's an absorption issue or like a production, pituitary issue? Yeah, so celiac panel, is somebody absorbing or not? Yep, so we could work up and see if she's having diarrhea or, pancreatic insufficiency. No diarrhea on this admission.
But even though she wasn't responding to IV,
What was that?
she wasn't responding to IV though.
Yeah, so her free T4 was coming down, I believe, with her IV. Let's pull up and see her labs. Yeah, so on her first days of admission, her free T4 went down, but then eventually came up by day 2, but her TSH was still remaining high and persistently elevated. And so there's a question as to whether or not she was responding even to the IV. Okay, so you can check a celiac. You can also check a B12. Sometimes there are hereditary deficiencies that can lead to abnormal absorption of TSH if their B12 is off. And so, while all of this is pending, I'm going to share with you her echo because Lynn wanted that. And so let me pull that up and then I'll have you guys talk through your general read of it. I will loop it so that way you guys can watch it a couple times. And then maybe if we can have a volunteer who wants to talk us through their impression of this, that would be great. Anybody want to take a stab at it? Yeah, so, and can you point out where you think the mitral valve is? I'll pass to you. Okay, so maybe that thing is moving a little more than it's supposed to. Any other comments by anybody? What were we looking for with her EKG? Yeah, so do you guys see a pericardial effusion? I'm seeing some nods, yeses, needle your closest. Can you point out where you see possible pericardial effusion? Okay.
Or maybe this guy. How do I erase? This is getting crazy.
Pick that, there you go. Yeah, so give us your final area where you think pericardial effusion is. Yeah, that's perfect. So let's label a couple of other things. So the pericardial effusion, I'm going to erase just so we can have labels on this. It's magic. So this space right here, you guys can see, there's a thin black line that's sort of surrounding the heart. So that's small pericardial effusion. The other things that you had pointed out are actually her ventricles. So this is her left ventricle, this is her right ventricle, and this is her left atrium, and her LVOT. Okay, so we see that there's a small pericardial effusion. Anything else you guys are noticing? There's just some LV hypertrophy as well.
That can explain some of the low voltage piece, which is like an infiltrative.
Yeah. So maybe a thicker LV than normal. And what about the pump function? Does it look like it's squeezing as powerfully as a regular heart? I'm seeing lots of no's. Okay. Do you guys want the final read from her echo? Okay. And so here's her read. So they say biventricular wall thickness, chamber sizes are normal. Her LV function is mildly reduced at about 50 with global hypokinesis. No significant valvular abnormalities and a small pericardial effusion without evidence of tamponade physiology. No prior echo for comparison. Questions, comments, concerns? Okay, so let's wrap up how she does. So she's here for a couple more days. We're pinning the results of all of those tests that we had sent off. And eventually her TSH does start to come down. She ends up from the 300s. She was about 360 on her last check, and she's down to 250. So, and that was with a combination of IV and oral repletion over a couple of days. And then her free T4 also starts to come up. She's about 0.3 by the time the team felt it was ready to discharge her. But we have all this other stuff pending, right? And so who wants to take a guess? I'll write down the labs again. So prolactin, IGF-1, those are probably the two biggest things I think that y'all are concerned about. And so any guesses, normal, abnormal, high, low? So we got a guess for high prolactin, high IGF-1. So you guys are like, yeah, this lady's gonna have something going on in her pituitary. What about her celiac panel and her B12? Any thoughts about that?
She was initially on a mix of IV and PO.
She got IV for 2 days, then PO, went back on IV, went back on PO. So
I said normal.
normal, okay, celiac normal. All right, so it turns out, yes, her celiac panel was negative. Her B12 was also normal, so no absorption issues that we found. And then actually her prolactin and IGF-1 were both normal. So it was a bit of a doozy from an endocrine workup. But I think that her case was really interesting because it highlighted that, you know, when things aren't fitting the picture, you sort of have to rework your problem and say, am I missing something for this patient? And so endocrinology thought that she just had very severe hypothyroidism after not having access to her medication for months. And they anticipated that everything would return to normal in a couple of weeks when she was on a stable dose of levothyroxine. But they agreed that like all of these labs should be rechecked once she's euthyroid to make sure that there's no concomitant factors going on there. And so presently, as it stands, she was discharged on, I believe it was 150 levothyroxine with follow-up with RAC and endocrinology to make sure that her levels continue to come down and normalize now that she had access to medication, with plans to repeat all of her hormone labs in the outpatient setting, just to make sure that those eventually normalized. Because her severe hypothyroidism could have caused her periods to be irregular, could have caused pericardial effusion around her heart. And so Endo wasn't that worked up about her in the end, but I thought she had a pretty interesting clinical course. And Lynn was actually the student who followed her, and Lynn can probably comment on what her face looks like and how her features were somewhat striking for possible acromegaly. I don't know if you thought that.
Yeah, she had really large hands, like in comparison to a lot of the other patients. And she had a pretty prominent jawline fatigue that we already talked about. And then she had like, I don't know if this is just me, but I thought she had kind of larger ears. But I don't think that.
Yeah. And so acromegaly is not very common. It's not, not a common diagnosis at all. And I would say that unless you think about it, you'll miss it. And so it's a very slow progression for patients. And so she, is probably not going to be diagnosed with acromegaly or elevated IGF-1 levels in the future, since they were normal when we checked them here. But it's always something to keep in your mind when somebody's coming in with like a pituitary-based issue. And so for her, I didn't tell you guys this up front, but she actually had a history of Hashimoto's and just didn't have her medication for a couple months while she was at Children's with her son. Yeah, it would have been boring if I just said that. So we had to make it more interesting. And I just wanted to add a very quick image. That way you guys can remember for Hashimoto's. So just taking you back to some pathophysiology, I'll make these a little bit bigger. So I gave you a key on the right for all of the different things that are in this little diagram. But if you remember for your thyroid cells, you have your follicular cells, which I've demonstrated here in the middle. And so these cells make thyroglobulin. And if you don't need it, what happens is that it gets secreted into the lumen and stored as colloid. Then when you have TSH, it binds to a receptor on the cells, and that causes thyroglobulin to come back into the cell. And once it's in the cell, your thyroid peroxidase enzyme will cleave it into T3 and T4, and then it's released out into your body as needed. And so individuals can develop antibodies to TPO, so anti-TPO antibodies, and you can also develop anti-thyroglobulin antibodies. And so if you look at her chart, You can see that in the past, she actually had positive anti-TPO antibodies consistent with her diagnosis of Hashimoto's. And so if endocrine is asking you to check certain things, that's where it plays a role in the pathophysiology. And that's why Hashimoto's can present the way that it does with the high TSH if they have antibodies to these two steps and their sort of thyroid production. Questions on any of that?
She just coincidentally aged in an acromegalis way.
Perhaps, yeah. Sounds like she's had a pretty rough life. And so I wouldn't be surprised if, between her living out on the streets and things like that, if she just hasn't had access to things like appropriate suntan lotion, skincare, dental care. Her hands, I don't know, I can't explain that. They were pretty large. So we'll have to see what happens. She'll get her labs redone in probably about a month from now. And so I'll let you guys know if anything interesting comes up on her repeat lab work. But yeah, I had to make the case a little bit more interesting for you guys. And I figured that hypothyroidism is not something that we talk about that often because we generally don't see stuff as profound as this. And so the key takeaways for all of you are if somebody comes in severely hypothyroid, pay attention to their vital signs and their labs to see if there's any evidence of mixed edema coma with hyponatremia, hypothermia, all that stuff. And if there is any concern at all, you should send a random cortisol. And if it's low, they have to get dexamethasone 4 milligrams IV before you give them any sort of levothyroxine product because you can precipitate adrenal crisis. And so there's something for you to keep at the back of your mind. Obviously, endocrinology is always around if you have a patient like this where you have questions. They're happy to help, but I want to empower you guys with some of that information so that way you can deal with it as it comes up.
Can I have my free teaching, please?
Yeah, Michelle's going to talk about hypercapnia and hypothyroidism.
It's only 12:52, so give me a little bit of time.
Yeah.
So you mentioned, I think, hypercapnia. Do you know how hypothyroidism causes that? Does anybody have any idea? Okay, so 25 to 30% of people with profound hypothyroidism, like starting with either an overt hemocoma, will actually have evidence of phrenic nerve denervation or phrenic nerve fibrosis and demyelination, as well as the diaphragmatic skeletal muscle fibrosis. So you've got diaphragmatic and phrenic nerve involvement. You also, in 50% of people, will see a decreased response to rising CO2 levels, and so your minute ventilation will not adjust appropriately. And then in around 30% of people, if you look at the pharyngeal space, you'll see similar to like the edema that you can get elsewhere with profound hypothyroidism, you can actually get pharyngeal edema. And so they get obstructive sleep apnea syndrome, OSAS. And so all of those things together put these patients at really high risk for respiratory failure. It can be really difficult to wean because some of that nerve and muscle involvement is not necessarily reversible. Which I think is just, I always forget how important the thyroid is until like it's not working.
Yeah, and you guys should always, like, if there's any question of mixed edema coma, the ICU is the correct place for that patient. And so never hesitate to like reach out to our pulmonary critical care colleagues if that's what you're concerned about. She was walking, talking just fine for how profoundly hypothyroid she was. So was not a concern for the team who admitted her.
And then equally exciting, Vocera's. So we would love you guys